switch to the current agenda. So basically, again, session 2's agenda is really actually to some extent what I just talked about. I mean, the students are here and what's going to happen and now what. And again, the more parochial your environment, I think the more critical it will be for you to really get them to get comfortable. I think the bulk of our time today is really going to be about the 1 Minute Learner. We have Derek Jeter presenting the 1 Minute Learner. Oh, Dr. Hoffman, I'm sorry. But the equivalent of Derek Jeter playing shortstop, the 1 Minute Learner is basically Dr. Hoffman was one of the core authors of this model, and it's a pleasure and an honor to have her come join us to present it. And again, I think I've really given you some idea of one of the patient ways to do this. I think what's so critical is also patient selection. In our case, my colleagues picked 2 parents that were very, very affable, very easy to talk with, that were very comfortable with patients. And I think that's also critical, is making sure that the patient problem and the patients themselves that they interact with will be actually really, really critical. Guys, Doug, you can switch it. And again, I think everyone should know, everyone here. I apologize for my mask, but I look real quickly. I think almost everybody on the call is someone we know. I'm Michael Giuliano, and as you might surmise, I was a clinical neonatologist before being the assistant dean for faculty, resident, student development. And actually, I'm not only overseeing and helping with the LCP program, but I'm actually a preceptor doing it. Dr. Martinez is the director of the clinical skills, and hopefully she'll be joining us. Obviously, Dr. Hoffman, aka Derek Jeter, playing shortstop tonight and presenting the 1 Minute Learner. Joe Martinelli and Doug Fabrizio, you probably all know because they're the leading edge of the LCP program and probably the primary people that you've been interacting with. And of course, Daniel Park is the LCP coordinator who makes everything run in the background and takes care of all of the major issues at scheduling and sets this all up. So everyone here is intimately involved, and there are many others that are involved in making this program work. Go ahead, Doug. So hopefully, by the end of this session, we'll have a real good idea of the challenges associated with getting this all done. I think it's going to be absolutely critical that, that we talk about exactly what we're looking for in terms of your practices. I think it's going to be absolutely critical to discuss how the students should be bringing their goals. And obviously for us, identifying appropriate patients based on the specific goals and objectives that they have. And of course, the bulk of the discussion we're going to have tonight really is going to be around the core model of the 1 Minute Learner. It's not the preceptor, it should be 1 Minute Learner. And potentially we can touch on the SNAPS model for presentations as one example. Go ahead. So obviously, Miriam, I think you probably want to take over from this point since, clearly we're talking about as you walk in the door. So Derek Jeter, you got a ground ball to shortstop.
Thank you. And I'm happy to, although Doug, were you going to do this piece or Michael? I'm happy to pop in just at the OML.
All right. Yeah, I'm happy to introduce it. So really the goal here is to kind of set the stage for the 1 Minute Learner and help introduce the reasons why it is so beneficial, along with the 1 Minute Preceptor and the SNAPS model, which we're going to talk about as well. But basically, we just wanted to start by reinforcing the fact that this is really the student's first clinical experience. So they've had their coursework, they're in phase 1, but now they're going to actually get, hands-on interaction with the patient. So we want to consider and put ourselves in their shoes and think about how they might be feeling. So are they confident? Are they anxious? Are they possibly overwhelmed? And then also consider the effect that a student arriving into your practice has on you and the impact it can have in terms of your efficiency or in terms of just making sure that you're training them throughout the day. So just think about the ways that this is going to affect both of you. Now, to do that, we really just put together 2 brief scenarios that outline kind of fun cases in terms of just how the student might be thinking and then what you might be thinking. And so I'll just read this very briefly. So let's just imagine that you're a new clerkship student and you're on a family medicine rotation. Today's your first visit. You hit traffic on the way in. You're already past the time you were supposed to arrive. And now you're trying to find parking, but it's taking forever. So you're stuck in the elevator. You're stuck waiting for the elevator to come, and your mind is racing about everything you're about to encounter. You're asking yourself questions such as, did I adequately prepare? What is today going to involve? And what happens if I make a mistake? So this, among many other concerns, are the things racing around your students' minds as they come to that first visit. On the other hand, what you might be thinking, or what might you be thinking? So let's just, another scenario, you spoke to your student a few weeks ago, but then since then you're out of the office and you've just returned on the day of your student's first clinical visit. So you arrive at the office and you realize that there's a pile of paperwork, labs, phone calls that need to be tended to. You've also double booked yourself for several sick patients that you really need to see. And so the fact that your student coming today has completely slipped your mind. You begin tackling your long to-do list and the student arrives unexpectedly. Oh no. So with that, these are kind of some of the background psyche situations that might be going on as the student comes to that first visit. And this leads into what Dr. Hoffman is going to describe with regard to the 1 minute learner and how it can help.
Awesome. And maybe if you can just go back one slide before we get to here, I'd be curious to hear. So when we talk about the 1 minute learner, we're talking about goals and expectations. And that's really what it's a tool to promote, is a proactive discussion about goals and expectations. And I would be curious to hear from folks, either from unmuting or chatting or whatnot, what benefit, why would it be important to have a conversation about goals or about expectations? You can comment on either one. What would be some of the benefits that you think could come from that?
Well, students are at different levels, and some of them might want to focus on taking a history and physical. Some might want to focus on just analysis of the patient and assessment and plan. So it depends, I guess, how much they've done in the past as to where they're going to want to focus. And it helps you to focus with them on their tasks.
And Charlie,
Absolutely.
would you mind introducing yourself, and when everyone else, if they speak, since we're all just getting to know each other too, if you just introduce yourself when you speak, okay?
Okay, I'm sorry. So I'm Chuck Weber, and I'm a rheumatologist down in Wall Township, and I work out of Jersey Shore Medical Center. And I've had a few LCP students so far, so I'm having my third and fourth LCP student right now during this phase.
Awesome. Wonderful. Great. No, though I think, and your comments were spot on. And I think we'll circle back to a lot of that. What are some other reasons why discussing goals or expectations might be useful?
Hi, this is Manisha Purulekar from Hackensack. I think it just sets the stage right when we start right off the bat what the expectations are, that anxiety and the stress on both sides, or that unknown is eliminated right at the beginning, and just makes things more easy for both parties.
Absolutely. Absolutely. Other thoughts that anyone has? All right, well, we can go on to the next slide here. And I think you guys really got at a lot of the key pieces here. So when we think about talking about expectations, and this was alluded to, right? What's your role? What am I supposed to do, right? If you think about it from the student's perspective, am I supposed to go there? Am I supposed to follow you? Am I supposed to take a history? This can really create a lot of anxiety. And, you know, we've all been through that sort of curse of the medical student where you show up, you're new to the service, you don't know where to go, you don't know what's expected. And all that adjustment that happens just takes up cognitive work that gets in the way of that clinical learning, right? And so if we can approach this in a more proactive way, we can minimize as much of that so that the student can really just get to the meaningful clinical learning. So it decreases their anxiety. It sets the groundwork for feedback. I think Dr. Weber mentioned goals, right? If you know that the student is going to want to work on the abdominal exam, well, you're going to want to give them feedback on the abdominal exam, and maybe you're going to be assessing that. So it really very much links to that. It's also very helpful for you as the preceptor, as Dr. Purulekar mentioned, right? Like they'll be able to hit the ground running if you understand what their expectations are and they understand what your expectations are. So the goal here is to get everyone on the same page. It's to be efficient so that everybody can get to those meaningful learning experiences sooner rather than later. On the next slide, a little bit about goals. And again, I think you guys started to touch on a lot of these. First of all, it's very student-centered. And we noticed when we first started implementing the 1 Minute Learner, and you see a lot of this actually in the business literature, where companies did things like make the meetings where people were sitting around the table, they never usually interacted and so forth. And there's actually a lot of benefit for me just looking at you and saying, hi, Doug, how you doing? And literally looking at you and using your name, right? And we all trained in that hierarchical kind of world. Don't underestimate the value and the power of what happens when you say to a student using their name, what are your goals? You've now set the stage, like Manisha said, right? In a very student-centered fashion that clearly communicates it's about their learning. So it's really going to build that relationship, which leads to more motivation on the part of the student, right? And really shows that their goals are important. Again, also that framework for what you're going to be assessing them on and what you need to do, right? Because maybe they need to focus on the abdominal exam, but you had all ear infections that day, right? A simple conversation can avoid any kind of mismatch there. So again, goal to get everyone on the same page. Okay, on the next slide, please. We like to talk about the 1 Minute Learner as a huddle. You guys are all familiar with clinical huddles. And PS as an aside, I did a session with the students exactly on the sort of student-facing version of this very presentation, I think about 2 or 3 weeks ago. So they've actually gotten this from the student perspective as well. They aren't as familiar with the huddle, right? I think, you know, as physicians, you guys see the value of why this sort of conversation in advance is really useful. As much as, and you're all in different types of clinical settings, like Michael was saying, inpatient, outpatient, and so forth. But if there is an ability to preview patients or plan ahead for who's coming or looking at who's on the service and incorporating that into these conversations, these proactive conversations with the students, that can be very useful. Next slide, thank you. So the 1 Minute Learner has 7 components to it. And there are different versions. There's the student facing and there's your facing, but the 7 pieces are the 7 pieces. They never change. I don't know if we have the ability, we can try to give you a 1 Minute Learner faculty card. I don't know if that was mailed, or we can definitely get it to you. This is the student facing card, actually. Again, the 7 pieces are all the same. We give students and we give you sample language because for some people that's helpful. More particularly on the student side, but for faculty as well. And I'll get to that in a minute. So there's 7 pieces and we'll just go through them quickly. The first is goals. And actually, Dr. Weber mentioned a lot of the really key pieces here. Goals has sort of 3 steps to it. The first is, what's their current level of experience or level of training, right? And so we're in first-year students now, but maybe some of our students we know were EMTs, or maybe they were a nurse, or maybe they had other types of clinical exposure. But you also want to think about it within your educational experience. How you see them at your first visit is different from how they are at their 6th visit. So you always want to start the discussion or the thinking about goals with where are you in that trajectory? So what's your current level of training or experience? Then it's what are their goals? And that could be both what are the goals that the clinical skills team has for them? You need to do an HPI, you need to do an abdominal exam, whatever it might be, plus what are their goals for themselves? And then finally, what are your goals for them? And you might have some initially, but you might not, right? It might be after a couple times that you say, you know, hey, I see you're really good with the ENT exam. I think we should focus on this other aspect today. And on the card, we actually prompt the students to both think about what are the goals for the course and what specific goals do they have for themselves today. So number 1 is goals. Number 2, getting going. And this is basically how should they start seeing patients? And this gets exactly at Michael's point of you're in all different types of settings, all different types of patients, inpatient, outpatient, and so forth, right? So what are the instructions? Pull the next chart from the rack and go see the patient. The nurse will put a green flag, that means you should go in. I'll walk you in and introduce you to the patient. Whatever kind of the instructions are, who should they see? Who should they not see? Sounds obvious, right? And a lot of times we might do this, but a lot of times we don't, right? And so if you think about it from the learner's perspective, where they're just supposed to kind of read your mind and know what to do, it's sort of the classic stitch in time, say it's 9. So goals, getting going, how much and how long. As I like to say to the student, there's not a lot more terrifying in life than being in there in an office with a patient, doing a history and physical, knowing that at some random point, the preceptor is going to knock on the door and walk in, right? Now think about that scenario from where maybe you said to the student, okay, go see Mrs. Jones in room 3. You have 20 minutes, do as much as you can, right? Or go see Mrs. Jones, take the history, and then come find me. Whatever the instructions are for how much and how long. And where should they find you, by the way, right? I've had students wandering halls trying to find where's that random charting room. They never told me what to do after I was done. Goals, getting going, how much and how long. Presenting, pretty straightforward. Where should they do it and how should they do it? And I think the point that the team put in here about planning, plan for this, right? Because remember, these are first-year students, so they're not going to necessarily be in the flow in the same way that a clerkship student might. So plan for it, build out that time, and make your expectations clear, right? Maybe you want to hear more detail. For this patient, we're going to pick one patient in the day. You're going to go through kind of the head to toe, or this patient, just give me the focused, pertinent positives, whatever it might be. Number 5 is charting. Similar kind of, and actually here, before we get to that, I'll hand it over to Doug.
So just very quickly, so we're in the presenting step of the 1 minute learner, which can be thought of as kind of an organizational model to help structure the day. To dive a little bit more deeply into the presenting step specifically as it applies within like a clinical context, we have 2 models called the 1 minute preceptor and then snaps. So the 1 minute preceptor is a model that helps structure the clinical conversation. And so it's helpful to imagine a scenario in which the student walks out from seeing a patient and they're maybe not so organized in their thinking, or they're not showing you enough depth of clinical reasoning. You can use the 1 minute preceptor to prompt them with these 5 different statements and questions to help pull that information from them. So step number 1 is get a commitment. So you're going to ask the student what you think is going on when they saw that patient. This kind of gives you a little bit of insight into where their knowledge and skill is at. Now you're going to ask them for the evidence that led them to their conclusion. So you can really start to think and see their clinical reasoning and identify gaps that may exist. Next, you're going to teach a general rule. So you can think of a clinical pearl or something that you as an expert would like to give them so that they can use it on an ongoing basis as they move forward. You want to give them positive feedback and tell them what they did well, as they are new learners, and these are, we want to build their confidence. And then you want to correct any mistakes that you identified. And so as our students are relatively new in the clinical hands-on experiences they're going to have. And so this is going to be a helpful model for you to structure those conversations and really get some good thinking out of them. Now, the SNAPS model is a little bit different. It's probably more aspirational. You can almost think of it as the inverse of the 1 minute preceptor, whereas with the 1 minute preceptor, you're kind of the one asking the questions. If a student is demonstrating familiarity with the SNAPS model, they're really going to be running through these steps on their own. So in a perfect world, the student is going to come out from seeing that patient and they're going to summarize to you what they saw. They're going to make it concise, but with the appropriate level of detail. Now, the next step is critical. So the narrowing phase, they're going to identify 2 or possibly 3 different potential diagnoses that may exist. And then the next step, they're going to analyze and discuss the discrepancies that make one or the other more or less likely. So this is really important to start to see how they can develop those differential diagnoses. Now they're going to proactively be asking you questions or asking things that they're not clear about that can help them. They're going to develop a plan for the future of that patient's management of medical issues. And then they're going to select a case to do further learning based on what they saw during that case. So again, these are just 2 different ways of building out that presenting phase. And so the 1 minute preceptor is going to be very useful right now. And then the SNAPS model is something to kind of be on the lookout as the students gain experience and familiarity.
Awesome, thank you. So number 5 is charting, and similar to presenting, this is basically when and how. We add to this as well. So first of all, you might want them to write up an H&P. They're going to have different assignments from the clinical skills team, whatever kind of post-visit documentation needs to be done. Always good to kind of be on the same page and answer any questions for the student in that. Number 6, questions. So when and how should the student ask questions? And are there good information resources that you would particularly recommend? And this sort of may sound like a funny one, but there are folks who say, okay, just ask me things that come up. If it's a bigger question, make a note on a card in your pocket, and we'll take 5 minutes at the end of the day to debrief any questions you have. And then number 7 is feedback, which is really important in terms of both closing the loop on that session and thinking towards the next one, right? So maybe you can do a little bit of a recap, point out things that the student did particularly well on, areas you think they should focus on, circle back to those goals that you set at the beginning of the session. Okay, you wanted to do the abdominal exam today, you did 2, how did you feel it went? And then you can give them your feedback from what you observed them doing as well. And again, thinking towards the next time. If you go on to the next slide there. So, a couple points just to make here. First is, I've presented on the 1 Minute Learner all over the place, and inevitably every couple times somebody says, yeah, I find this helpful, it's good, but it didn't take me 1 minute. And I sort of chuckle and I say, it's a catchy name. It was inspired by the 1 Minute Preceptor. The reason I mention this, though, is that you're not going to necessarily do all 7 steps every time, right? The first couple times you have a learner with you, and by the way, this can and should be used with all learners of all types across all levels of training. You might do quite a few of them. You really might go through it, what are your goals for the whole course? You're going to orient them to where the flow is. You're going to tell them how things are going to work in terms of seeing patients and so forth. But once you've worked with the person a couple times, you really might just hone in on goals, right? What are the things you need to focus on today? And feedback and things like that. And a little bit of a foreshadowing for what I believe is the next session, where you guys will do a deeper dive with the forward with feedback model. So, again, the point is to have the conversation happen. I've also had situations where students say to me, yeah, the 1 Minute Learner was helpful, but I didn't really need to use it because my preceptor sat down with me on the first day and we went through what my goals were and what I was supposed to do and all that. And I said, that's awesome. My goal, I make no money from pocket cards, although I wish that I did. The goal is to have these conversations happen in this sort of proactive way. And from the student facing side, sometimes it is helpful. There are students who like to have the thing that they can pull out and say, oh, we're supposed to do this. And we've gone through with them kind of the language so that they can be proactive and that they can initiate these types of conversations. Next slide. So we did study this way back. This was in the first year that we did sort of full implementation. I think it was maybe 2014 in one clerkship. We then expanded it to all the clerkships at our school, then pulled it into pre-clerkship, and now it's being used actually across the whole world. And you can see this was a simple little cohort study, but you can see the dramatic impact that happened here. And I can tell you the genesis story of it. Actually, the way that we developed the 1 Minute Learner originally at the clerkship level is I would meet with the students halfway through the clerkship. I was the clerkship director at their mid-clerkship meetings, and they would say, oh, I'm having a great experience. Dr. B is terrific. I'm learning so much. I just wish I could do a little more of this. And I would say to the student, okay, why don't you go and talk to Dr. B and say, hey, Dr. B, it's great. It would be great if I could only do a little more of this. And I literally had an aha moment where it occurred to me, why don't I just have that discussion with the student at the beginning of the rotation before they've spent half the time not being on the same page? So it really makes, again, gets that sort of anxiety as much as we can out of the way, gets you and the student on the same page on all of this. And it's much more effective learning for the student and much more satisfying for you as the teacher. I think that might be the last OML slide, is there? Yeah. So happy to talk about anything more you guys want or answer questions or kick it back over to Doug.
And Mary, would love for you to stay on board. But, again, I think, when you think about the 1 minute with the 1 Minute Learner model, you realize how absolutely critical it is in terms of patient selection. And especially graded patient selection in terms of the complexity of the problem, the nature of the patient and the interaction. I have to be honest, I told my colleagues today, I really want some nice parents that'll be relatively easy, that aren't anxious about their baby being super sick, and obviously wanted a very simple problem. So despite the fact that they were actually put in the neonatal intensive care unit, we actually started upstairs in Well Baby, with very low intensity patients that were healthy, just so that they can sort of get their feet wet, since this was their very first interaction. And then the patients we had in the unit were also relatively straightforward. So again, we're only seeing them 6 times, which is a relatively short number of times, but it's over a pretty long period of time. So hopefully you'll get a sense that they're going to have deeper and deeper complexity of understanding of physiology in particular as they progress over the next 3 or 4 months. And indeed, the complexity of the patients potentially can increase. I think one of the important points I'd like to make, especially in the groups that are having students come to a specific setting and there are lots of people involved, we really want to try to concentrate the number of people connected to the given students so that you get a sense of longitudinal improvement and get a sense of how they are improving over time, which obviously make the feedback and coaching much richer and much more meaningful for the students and for us. So for example, in the neonatal unit, we have a pile of people who volunteered, but basically Dr. Planer and myself will be taking turns basically working with the core set of students that we have to have continuity with the students, and also to make these kind of decisions about the degree of more complexity and where the students are in their growth curves. So I think that will all be really sort of important to do. In the chat, I mentioned that the expectation was a write-up per visit, and that is my understanding of it. I don't think Ophelia's joined us. I hope she could clarify it, but my understanding was that since there are only 6 visits and they're over a relatively long period of time, my understanding was the expectation is they write up one of the patients that they saw in the afternoons that they interact with you, and that write-up should come a day or 2 after they've left, not be done while they're there, not consume that time in the write-up. The time together should really be about seeing the patient, getting a full history and a physical. The other part of this that I think is really critically important is nobody expects everyone to be sitting with the student the 4 or 5 hours. Clearly, that is not something that we have an expectation, or quite frankly, would that probably be doable. But again, the goals of the students in a particular session should probably be the key to the timing of how much time you spend actually with the patient and the students. So for example, today, all of our students came and their primary goal was building a quick therapeutic relationship with a patient that they've never met before to take a good history. So I made a point of staggering the students seeing patients and actually be in the room as they introduced themselves and they started to build that initial therapeutic relationship with patients, and then commented to them about how they did that. So I think it's important that we observe the parts that they're particularly interested in terms of seeing. So I think that's really, really critical.
It is. And a couple thoughts to add. And I just messaged Ophelia and she said it's 1 after each session. So
yeah, that's what I
think
thought.
that was what
well.
Mark voted for. So he got what he wished for. I just wanted to build off of what you were saying, Michael, because I think it really pulls together a lot. And if you think about goals, this is really the meat of the OML, or if you had to sort of pick one most important part. First of all, what is the student's current level of training? This gets to what you were just talking about, right? Like this is literally their first time, right? For most of them in the clinical setting. So we have to be aware of that. At the same time, we have a lot to cover in these 6 sessions. So it's really important that you guys are actively thinking about where they are in that trajectory. Like we said, what are the goals and where are they starting from? But I want to emphasize, what are your goals for them? Because there will be some, and by you, I mean you, but also kind of the clinical skills team overall, there will be students who it's harder for them to jump in and they might need a little bit more of a gentle push. I don't know, Alexa, if you want to describe what you did, but she did a really wonderful thing with her students, kind of really throwing them in and diving in the emergency room. So you want to use, I think, the 3 parts of goals to balance all of this. Where are they? They're early. We have big goals for our students. You guys know that. We set the bar high, right? And we need to be able, and this is where the OML as a tool will help you flex for the student who's just diving in head first, the student who's maybe a little bit more hesitant, and then really being cognizant of what are the milestones that the curriculum wants them to hit.
Yeah, thanks. Thank you. Oh, shoot, there's my dog in the background. So this is Alexa, Maisie, shh, Alexa Gatian. Maisie, I'm at Englewood Hospital. So I played the sick, not sick game with them in the ED, where we just go in and we introduce ourselves. I'm kind of chatting family members and giving them a chance to just really look at patients and do a clinical assessment of whether or not this is somebody that they see as ill or not that ill. And then we left the room and we kind of talked about it. And we sort of did that down an entire length of one side of the ED, and then went back and sort of gathered more information about the patients with some of them, and then some of them we just sort of went to the medical record and got more information. But it was actually, I was incredibly impressed with how well they could just master an initial clinical assessment. And I also incorporated the whole concept of type 1 and type 2 thinking as part of it, which again, it was a nice exercise to do with them.
That's a great idea. Interestingly enough, one of the things that I find is that, and I think this is just because our standardized patients who they've interacted with up to now, to a large extent, they're very well educated people who have a vocabulary of a college educated person. And the reality in the real world is that indeed our patients have very different levels of education and vocabulary and interaction and medical knowledge. And I actually emphasize with the students to try to make a conscious effort to sort of get a sense of what they thought the medical IQ was of a patient, because I think they often jump into jargon. And it's just that it's a byproduct of the fact that all the SPs they've interacted with are all pretty educated people. But that's another part that I think is absolutely critical to, to get the students to have a sense of, is that, people are coming at them from very different places, and they need to calibrate that appropriately when they're talking with them. Any other questions, comments, experiences? Steve, you're still muted.
Thought I was
There you
unmuted.
go.
So thank you, Michael. So Steve Percy from Pediatrics at Hackensack. You talk about doing presentations and you talk about write-ups. What teaching have they had so far in terms of how to do a standardized presentation and write-up? Are they familiar with it, or is it something that's going to be new to them that we should be taking them through?
It's fairly new. Their ability to actually do presentations have been relatively limited because everything's been in small group. So each of them, and in PPPC, and the Friday morning, Steve, you have some sense of what they're starting to do with those, sort of give me one line about what the patient's going on summaries. But they've had very limited experience, especially in trying to sort of create that summary, short summary statement. And they've had relatively limited experience in doing a presentation, overall presentation and organization of a patient. So you really should take them from square one.
Okay. The reason I asked, my students in PPPC have asked what form presentations are going to take. And I said they actually take exactly the form that you're seeing the case being presented on Friday or on Monday mornings. And so that's what we really use. And we don't look for a lot of creativity of how to do it. It's really a very standardized process.
Exactly.
And we as clinicians expect certain things at certain times. And when we don't hear them, then we get all verklempt and went off in different directions. Why didn't they tell me about that? And things. So they have asked me, what way are we going to be presenting? I said, this is actually how it is. So we'll just reinforce that then as we talk to them. So
exactly.
So
actually,
Alexa,
one of the students asked me today, what's the format? What's the format? I said, you use the standard format that you've been used to. But of course, the history of the present illness should always be formed and focused on the problem and what the diagnostic reasoning that's embedded in it, as we would all do.
Now, I think another thing that we were looking to get some conversation going about was just hearing from anybody who has implemented the 1 Minute Learner with this program in the past, and if they had any recommendations in terms of how they could incorporate it in a realistic fashion, how long it actually took, and maybe what some of the benefits were of using it.
Chuck, you've had students before. Miriam suggested it's more a 10-minute learner. I have another point estimate. I'm curious what you think the point estimate is.
Well, instead of using the 1 minute learner, we go in with the patient and we do the whole patient together. And I ask the students question all throughout the history and the physical and through the assessment. So I kind of drag it out into the entire almost hour that we spend with each patient, rather than condensing it. So every time a topic will come up. For instance, if the patient has edema, we'll go through pitting edema and go through the differential and then discuss it, and then we'll go on to the next thing that the patient might present with. So it's a little bit more elaborate than the 1 minute learner.
So Chuck, you want to rename it the 1 hour learner?
Yes, definitely.
Okay.
How about the lifetime learner?
Yeah.
Yes.
Oh, I like that one, but I don't know how catchy that one is.
I don't know either. So I don't think I've used it formally. I use many of the elements that Miriam has talked about. I think for myself, what I will pay more attention to going forward is asking them what their goals are, both for current and future sessions. I think that's very important so that we're on the same wavelength. And so, this is 6 sessions as opposed to the 3 that I've done in the past with the students. So I think this is going to be nice to be able to take us through the ability to really see them develop a skill set that perhaps couldn't be done in 3 sessions. It was more an exposure to the patient and how you start to talk to absolute strangers and ask personal questions and how you deal with that. And I think having 6 sessions over, I think 6 months, right, Ophelia?
Yes.
Is going to give us an opportunity to really see them develop a skill set that they perhaps don't have now and could not have developed in just 3 short sessions.
I want to be respectful of people's time. We're all already a little bit over. I see everyone's still here, which is a good sign. But Dr. Martinez, thank you so much for dropping in. I know you had multiple other things. We've already discussed pretty extensively some people's initial experiences and the 1 minute learner, which Chuck thinks should be a 1 hour learner. I actually renamed it the 10-minute learner, but wherever, would you like to add your 10 cents to the conversation before we let people go?
Really just to thank you all for really making time to mentor and to teach the students. And please, any questions or any concerns that you might have, please feel free to reach out to us. The students are extremely excited, as you might imagine, to get to work with you all. So really, absolutely, these are experiences that are going to stay with them. So thank you.
I would like to end on the fact that this was the first clinical interaction this group of students had literally today. I just came from it, and they were jumping out of their skin. It was really, you could see there was obviously a little bit of nervous tension, but they were absolutely jumping out of their skin because they had finally had the opportunity to interact with live patients. Actually, one of them said, they're nicer than the SPs. So it was wonderful to see. And again, it's so critical for everyone to recognize that this is such a formative experience for them to have this first initial clinical experience. And you're role modeling your professional behavior, your lifelong learning, creating a positive learning environment, creating a positive interaction with your patients is so critical to their professional development. And I can't emphasize enough both how grateful we are of your involvement and how critical it is to the overall process of development for these students. So we have full hearts of gratitude, and we're eager to see you again in approximately a month. We're going to be planning these monthly with very pertinent topics as we move through. And if there are needs that you have that you feel that we're not meeting, please reach out to us and we'll be more than happy to address that. And if there are any logistical issues also, please don't hesitate to get in touch with us.